Hello everyone, my name is C. Wayne and I go by Allison. I am in my third semester of the Family Nurse Practitioner DNP program. I am a registered nurse on an intermediate cardiac unit at Emory University Hospital where I take care of a lot of patients with acute heart failure. I frequently administer diuretics like furosemide to these patients to manage their symptoms. Almost all of my patients who are on diuretics like furosemide suffer electrolyte imbalance, leading me to use a lot of my clinical time chasing their potassium and magnesium levels. Sometimes these electrolyte issues lead to cardiac dysrhythmias. This recurring clinical issue sparked my interest to investigate current diuresis therapies, and I hope to identify strategies that can improve current practice. And my topic is called Diuretics in the Treatment of Acute Heart Failure. According to the CDC statistics, about 5.7 million adults in the United States have heart failure. Heart failure results in 1 million annual hospital stays and 6 million hospital days in the United States. It is the top reason for Medicare hospital readmission. Heart failure treatment and related expenses cost the nation $30.7 billion annually. Acute heart failure, also known as heart failure exacerbation, is the most common cause of admission to the emergency department in patients greater than 65 years of age. In the United States, acute heart failure is a major challenge to emergency departments and consumes significant resources. Problem identification. In patients with heart failure, fluid retention is often the stimulus for acute heart failure. Patients admitted with acute heart failure has rates of rehospitalization or mortality approaching 50% within 6 months. Despite the alarming statistics, little advancements have been made on treatment therapies for patients with acute heart failure. Currently, loop diuretics like furosemide represent the mainstay of therapy for acute heart failure. 90% of patients hospitalized with acute heart failure in the U.S. receive IV loop diuretics during the hospitalization. Diuretic agents reduce symptoms of acute heart failure, such as shortness of breath and fluid retention. They also improve patients' quality of life. However, loop diuretics like furosemide have been consistently associated with many side effects and adverse events, including hypokalemia, hypermagnesemia, hyponatremia, azotemia, hypotension, impaired kidney function, and increased mortality. Older patients are at an increased risk for worsening renal function and diuretic-induced electrolyte abnormalities. Loop diuretics cause a substantial loss of magnesium and potassium in the plasma and intracellular space. These deficiencies are known to cause cardiac arrhythmias. Fluid management and electrolyte monitoring are major nursing responsibilities in caring for acute heart failure patients. In caring for heart failure patients receiving loop diuretics, nurses spend a significant amount of time managing electrolyte disturbances and chasing patients' potassium and magnesium levels. Bedside nurses are often the first persons to detect symptoms that represent hypokalemia, hypermagnesemia, hypotension, etc. Chronic loop diuretic use in patients with acute heart failure have been associated with worsening congestion, more renal damage, increased mortality, and increased readmission rates. Higher diuretic doses during hospitalization are associated with increased mortality and poor 6-month outcome. Based on the existing issues With loop diuretic use, I came up with a problem statement. Although the conventional clinical practice of using loop diuretics like furosemide to treat patients with acute heart failure remains the mainstay treatment therapy, data shows high dosage of furosemide leads to electrolyte disturbance and renal damage. In some of my patients who have acute heart failure, tolvaptan has been used in their treatment in addition to furosemide. It is used to improve urine flow without causing the body to lose too much sodium. Therefore, I want to see the impact tolvaptan has on patients' prognosis versus that of furosemide. Thus, I propose the Peacock question. In patients greater than 65 years of age with acute heart failure, how does adding tolvaptan to furosemide compared to higher doses of furosemide impact patients' renal function during hospital stay? So the Peacock components, P for population, are patients greater than 65 years of age with acute heart failure. I for intervention is adding tolvaptan to furosemide. C for comparison is compared to higher doses of furosemide. O for outcome is the impact it has on patient's renal function, and time is during the hospital stay. The independent variable in this case is adding tolvaptan to furosemide treatment and higher doses of furosemide. The dependent variable in this case are patient's renal function. These are my references, and I want to thank you for spending the time to listen to my presentation.